People going to intensive care unit have invasive mechanical ventilation or support for 2 or more organs. Of course, that is this very highly skilled nursing that there are not too many because there are very qualified nurses. I don't know if here we have problem or not to have very good nurses, but in Argentina there are very few, and you need just to have better payment for that patient, that nurses, that is not, normally is not happening in the public hospitals, but anyway, we are very good nurses, of course. But where this unit could be located, I think that this kind of unit, that is a special care unit, could be located in any places we have a obstetric department. Because in any place we can have some consultants or doctors in the last years of the residential program that can stay there, that can look in this lady. It's a place located close to the doctors on call, because doctors on call are just taking care during the whole day of these ladies who are there. Normally these ladies are pregnant and has not babies there, because in generally after delivery most of the problems are solved. And if it has a previous disease, a very, for example, I don't know, you can say a very important heart disease, for example, that you can just taking care of the lady during pregnancy, but after pregnancy maybe they need just to move this lady to the cardiology department for any treatment. That means that it's very difficult to have the babies there. It's more common to have only pregnant ladies just to be under control. But that means that another term appears. How you call the doctor? How you train the doctor who are working there? And that doctors are intensivist obstetricians or intensivists with the knowledge of obstetrics. That's harder. That's very difficult. Or you can create a critical obstetric as a new specialty. Maybe a doctor that age that me and the other doctors, we can just think about that. Because I make the comparison between obstetrics and gyne. When we are talking about gynecology, the people, the consultants that were working just specialized in gyne, they create many subspecialties. Gynecology, endocrinology, gynecology, oncology, fertility and sterility, many invasive procedure, etc., etc., etc. And every year is a new subspecialty in gynecology. But in obstetrics, all is the same. What is that? Everything is the same. You are an obstetrician, and you can take care of the lady with low-risk pregnancy or high-risk pregnancy. We can do everything. We can do just the only subspecialty is maternal fetal medicine. That is more fetal medicine than maternal fetal medicine, and that is true. In my department, maternal fetal medicine is fetal medicine. It's prenatal diagnosis, it's intrauterine growth retardation, it's malformation, it's intrauterine treatment, etc., etc. It's just looking at the fetus, not the mother. And the mother is taken care by obstetrician, general obstetrician. And I think that we need just to train more obstetrician just to take care that the lady for work, just to look at this high maternal mortality in the world. Because most of the cases that where the ladies are dying because of pregnancy or during delivery is because also in places where there are doctors on call, they didn't realize that doctors that the die could be happening this lady. They never know that maybe you have 10 pregnancy before and 10 delivery before. This lady could have an atony or could have a uterine rupture or could start with a very important hemorrhage, and they didn't know how to treat the postpartum hemorrhage. And the lady can die in 5 minutes. Okay. And I want to see that this is an important point. We are just working on that in our department. And also we got hematologists working in our department, specifically nephrologists and hematologists working with us. And also for the other specialties, it's very interesting. Because normally nephrologists see many patients and some pregnant lady, but when they are involved specifically with pregnant lady, they start making very interesting cases and they contribute to the treatment, just to improve the treatment for lady who have also kidney disease. And which I just look into the literature and find there is a program at the University of Mexico, and yesterday at the Cornell they told me that there is one the specialty is recognized for the here in the United States. I didn't know before. Then they said that it's recognized for the American College. They told me, no, but I don't know if this is a course or there is really a special training. Because also when I see there are many courses, but most of all of that courses are in charge of the people from the intensive care unit, from the intensivists, and giving courses to the obstetricians, no, at that time. Okay, what I said that requires consideration, of course, socioeconomic stratum and the center of choice, because just to see, we need some money just to design again some services. But I must say that it's not expensive to have this unit, because it's just to put together not with invasive procedures. It's not so expensive that to have the ladies in different parts of the world. It's just to put all the ladies together with the doctors more training just to taking care of that ladies. And also it's good for doctors in training, and you can work in the team, like we are now sitting around this table, with different specialities and discuss the different problems that I book in that unit. I think this could be important to be considered. Of course, you got too much to learn about that. You need more experience, and there are tests that appear that you can recognize. Early in pregnancy now, there are some tests that appear to make a probability to become hypertensive during pregnancy. Many other things are coming. But we need to still thinking about the ladies, and to still thinking about what happened in many other parts of the world, and to be involved, because here it is important, because in this country especially, where people from all over, that maybe most of those people are coming back to their countries, and they just make some change that is some part also of our work. Okay. I finish here because I think that you need just to go back to work.
Right on time.
But yes, exactly on time. But if you like just to make some questions or some comments, I'm ready to hear some comments about that, if you agree or not, if you have this quality of things in that institutions.
Okay.
It's a very interesting concept about this, like a mid-level thing. We don't have it here like a mid-level thing. We usually send our patients to the intensive care unit, or what it could be like a mid-level is a recovery room, when we put our patients like for magnesium with preeclampsia to monitor, or the patients that have some bleeding that we just want to observe for a little longer, we keep them there. If we think that they require like more close monitoring and everything, then we send them to intensive care unit and we co-manage with them. That's the way we do.
Yes, but this unit in general that is to say that to put the magnesium sulfate, etc., you have this part in the place that we call the perinatal center. Perinatal center is the place that you have the labor delivery and recovery rooms, and the theaters, 2 theaters, and at the same time there are some places that to put the lady when they receive the magnesium sulfate and to observe during the day, and then they are transferred again to this unit, okay, because they are not all the time with magnesium sulfate. That's for specific treatment, also to give some gamma globulin in the case of RA disease, and etc., etc.
This is a very good lecture. I think what brings out is that, for example, patients who come with hypertension or preeclampsia and are at risk for cerebrovascular accidents, if they have a high blood pressure of over 160, there's certain parameters, and they'll be for example, people who come in with hemorrhage and after D&C or something, they come in with low platelets and they're not given the FFP platelets and blood right away. Instead, they're given saline. The patient comes in with a severe headache, with blood pressure of over 160, systolic with a change in blood pressure of like 60 points from pre-pregnancy. These are the parameters that get us undersided, and this is how we get in trouble by not recognizing these patients are in trouble when they come in, and that they're sliding under and going into a dangerous parentheses. So this is very good that you're bringing these things up, and these are the type of things that we have to look for. Patients who are ready to have a cerebrovascular accident, patients who are ready to seize, patients who are having preeclampsia, and looking at studies to show that, for example, that 50% of these patients don't have a high protein, but they had a high blood pressure of systolic, not diastolic. So these are the things that we're looking for them, and we have to look at the latest studies to show which patients get in trouble. We're far ahead of the game, and we don't get into this many problems.
Yes, especially in our hospital like this one, or my hospital that are public hospital, that maybe the patients who are coming need to be booked because they can't go out and into the hospital many times. It's specifically just to keep it there and to keep it under surveillance, because it's a high risk to send this lady at home.
Right, just recently we had patients who had sleep apnea, patients who are getting fluids and nobody listens to their lungs. There's somebody who has H1N1, or even giving Tdap early in pregnancy instead of later pregnancy. So if we can listen to these, all the studies that come out, watch them closely, and have this specialty of intensive care where we know what's going to cause those 3 patients that go to the ICU that have a maternal mortality, and get them early because it's easy to learn from that. We'll be far ahead of the game.
Okay.
Thank you very much.